that Dr. Tabane suggested it. And I hope we have many, many more. Being able to lean into professionals when these kind of topics come up is critical because we don't have all the answers. Couple of little quick things. I just want to ask you all, when Dr. Tabane starts her presentation, if you can switch off your mic and switch off your camera, it'll make the quality of everything a lot better. Any questions that pop up, put it in the chat, or if you know what it is, we'll have a Q&A right at the end. And we will address all of those questions then. A couple of you have sent questions into me as well. So if it isn't covered, we'll go through it. And then finally, just we may all have some different opinions, but let's just be respectful and kind in how we address it and have those conversations going forward. Just to introduce Dr. Tabane, for anyone that doesn't know her, she is an oncologist from 200 Rivonia Road that is very accomplished and very well known and who we absolutely love. She has supported Sisonke Sisters from the beginning, but more than that, she is very dedicated in how she supports her patients, and we see and know that on the group, and so appreciate that. So I'm going to hand over to you, Dr. Tabane, and we'll take it from there. Thank you, thank you, thank you again.
So thank you very much, Dawn, for arranging this. I'm very pleased that we can have these kind of conversations outside the confines of an office and outside the intimidation of an oncology center. Oftentimes in the meetings, it sometimes feels like there is not enough time to go over everything. So I'm glad that we're doing this today, and I'm hoping for an engagement where we can discuss, I can explain, and I can also hear from you what actually matters to you. So this is not just a one-way thing of me just pouring out information, but it's just a morning of sharing together. So I am going to be talking about genomic profiling and how it helps all of us in essence. So what is genomic profiling? So basically, genomic profiling is when we look at a cancer and we try and see the biology of this cancer, what I like to call the signature of the cancer. A lot of what I'm going to be talking about today is for early stage breast cancer. So that is a cancer that is localized to the breast and or the armpit that has not spread anywhere else in the body. So that will be the focus of today's topic on genomic profiling. Although we do genomic profiling when a cancer has gone somewhere else, I thought today I just wanted to zone in on genomic profiling in the early stage setting. So we basically, you would have had either a biopsy or an operation, and then we look at that cancer to try and help us see what is the best way forward. The commonest reason that we do genomic profiling in early stage breast cancer is to see whether you need chemotherapy. Because the biggest question often after the surgery or even after a biopsy is, will I need chemotherapy? And I want to say that most women don't need chemotherapy after they've had surgery. So when we do this profiling, it helps us to answer that question, to give us more confidence when we make a recommendation for or against chemo. So it looks at the genetic makeup of a tumor, and it helps us to predict how this cancer is going to behave, what is the likelihood of it returning, and what are the tools we can use to deal with that, be it hormonal blockade only or hormonal blockade preceded by chemotherapy. So it helps us to guide treatment. Genomic profiling does not answer the radiation question. It does not tell us whether you need radiation or not. The indications for radiation are different. For example, if you've had a lumpectomy and not a mastectomy, or if there's positive lymph nodes in the armpit and so forth. So that question is answered from the pathology, from the kind of operation. So this genomic profiling is not answering the radiation question, but it's rather answering the chemotherapy question. So it takes the guesswork out of trying to determine what you need. we can confidently then know from looking at the genetic makeup of the tumor and seeing how it's likely to behave, what is the best way forward. Now, there's a difference between genetic testing and genomic testing. Genetic testing is what were you born with? What is in your genetic makeup, in your DNA, that potentially has brought this diagnosis of breast cancer? So it tells us about your family history. It tells us about what is the risk that your family carries now that you have been diagnosed with breast cancer. Because often you'll say, should I test my children? Should my sister be testing? This is what the genetic test tests. So it tests the woman, either a saliva test or a blood test. This does not test the cancer. It just says, are you at risk of other genetic? Is the reason for this cancer a genetic one, right? Is your family at risk? And how we test is that we would test the saliva or the blood. Often we would test if there's a strong family history, if there's very young cancer, if there's 2 or more people in your family who've had like sort of breast, ovarian, or young prostate cancer in men. So that is the testing of the woman. It tells us about the risk of the family, and we test the blood or the saliva. Genomic testing is the genetic makeup of the tumor, and it tells us what the best treatment for you is. And there we test the cancer itself. So we take material, we send it to, it either goes to the US or to the Netherlands, depending on what test we have chosen to do, to test the cancer itself, to see what is the best way forward. So this is an important distinction, that the genetic testing tests the woman, the genomic testing tests the cancer. So today I'm talking about the use in early stage breast cancer, but I must emphasize that this is applicable only in cancers that are hormone receptor positive and HER2 negative. Now, hormone receptor positive, just to go back to the basics, is when the cancer thrives on estrogen, when the cancer needs estrogen to grow. It means that on the surface of the cancer cells, there would be like receptors, like antennas that bind estrogen. And once the estrogen is bound to the antennas, it sends a signal to the middle of the cell to replicate. So those are the cancers that are driven by estrogen and that don't have an over excess of a protein we call HER2, which is a protein that is present on all breast tissue. But 20 to 30% of patients with breast cancer have got too much HER2 protein. And that's when we say one is HER2 positive. So when the cancer is positive for HER2 or negative for estrogen, like the so-called triple negative breast cancers, those need chemotherapy. So the genomic profiling I'm talking about in the early stage cancer, breast cancer, is not applicable to the triple negative breast cancer population or to the HER2 positive breast cancer. And this is very important. These require chemotherapy, and these can be the subject of another webinar in the future. Today, the genomic profiling we are talking about is relevant for hormone receptor positive cancers and HER2 negative cancer. Now, do all women with breast cancer require chemotherapy? And the answer is a resounding no, right? Not all women require chemotherapy, and so genomic profiling helps us answer this question. So in the early days when these trials were happening and this research was happening, it emerged that 30% of women who receive chemotherapy, they don't need that chemotherapy that doesn't help their outlook. And in fact, even when we were training many years ago, the teaching then was that anyone who had a tumor of more than 2 centimeters needed to have chemo. Anyone who had positive lymph nodes needed to have chemotherapy. And we've subsequently learned with new research and all this personalized tests that in fact that was over treating at least 30% of women. So there's different kinds of tests that we have available. We, as in South Africa, have 2 main tests, which is the Oncotype DX test and the MammaPrint test. But there's other tests that you could read about, like EndoPredict, PEM50, and but the tests that are mainly available to us here and used quite widely all over the world is the Oncotype test and the MammaPrint test. The tests are all slightly different in that they test different amount of genes, and also they are reported differently, which I will show you in the next couple of slides. The Oncotype DX looks at 21 genes, MammaPrint looks at 70 genes. The Oncotype goes to the US, the MammaPrint goes to the Netherlands. The turnaround time from when we chat in the rooms to when we actually chat again to get the result is about 4 weeks. That includes about 7 to 10 days of medical aid authorization. By the time the specimen gets to its destination, it's 14 days in the lab. So it takes about a month, which is okay, because often it's soon after surgery. You still need that time to recover anyway. So that 4 weeks is time well spent learning about the cancer, trying to make the best decision so that we do not rush to the wrong place with treatment. So there's different ways that the tests are reported, but in essence, for example, the Oncotype score test is reported as a score. A low risk score would be something like 0 to 11, 11 to 25, it's intermediate, over 25, it's high risk. So if a score comes and it's like 2, it means it's a low risk. And the trials then showed before, and now we know that low risk score means there will be absolutely no benefit from chemotherapy. And of course, the side effects of chemotherapy, as you know, are guaranteed, but there will be no benefit at all. And so we can then confidently say to you, you don't need chemotherapy. But we must remember these tests assume that the woman is going to take hormonal blockade. That is the heart of this test and this result and this foretelling of what we think the cancer will behave like is that there's a sort of assumption that the woman will take hormone blockades, right? And so a high risk score, on the other hand, means that this cancer is aggressive, has a high risk of returning locally and distally, i.e., showing up somewhere else later, and that the woman then requires chemotherapy followed by hormone blockade to reduce the risk of this occurring. Remember that this does not answer the radiation question. That would have already been answered by the kind of surgery that you would have had, or the involvement of lymph nodes, or the size of the tumor, like a tumor of more than 5 centimeters requires radiation treatment. So a couple of myths have then been busted, and I already spoke about a few of them, of how when I was training in 2006, this is what we were told, and subsequently we have learned that that is not true. So not everyone with positive lymph nodes needs chemotherapy, right? If we have a low-grade tumor that has just been there for a long time and eventually went to 1 or 2 lymph nodes, that does not render the cancer aggressive. And that is why we now still need to check to see whether, in spite of lymph node involvement, that whether chemotherapy is required or not, right? Not all tumors that are bigger than 2 centimeters need chemo. It could be a low-grade tumor that's just been there for a long time, turns out to be 3-4 centimeters. That does not now suddenly mean that it's going to require chemotherapy. Before, we used to think that all young people must be treated with chemotherapy. Granted, younger people tend to have more aggressive disease, but we still need to look at the biology and take it all together, look at the biology, look at the other risk factors, look at the pathology, the genomic profiling, put it all together, weigh up the actual benefit versus the risk, discuss with you in a shared decision, and then make a decision together. The converse, though, is that small cancers can also be aggressive. You could have a little aggressive cancer. And so even sometimes when the tumor is tiny, 5, 6, 7 millimeters, if the biology lends itself to aggressive behavior, we would still consider and offer a chemotherapy if the genomic profiling says so. This is just an example of an Oncotype test of a patient who was postmenopausal, who had a positive lymph node, sent off for an Oncotype test, and the recurrence score is 7. 0 to 11 is a low risk score, and so 7 is certainly low risk. You can see here that the estimated percentage of recurrence at 5 years is only 2%, with an aromatase inhibitor like Laradex, or with tamoxifen alone. And so there is no chemo benefit. It's less than 1%. There is no reason that this woman should be offered chemotherapy. On the other side, we have another younger woman, premenopausal, also with positive lymph nodes, but came with a really high score of 48. And so here again, you know, the recommendation then was of chemotherapy because the risk of recurrence at 5 years exceeded 12%, which is the threshold of significant risk. The mama print test looks a little bit different. It's reported differently. So here they give a score and it's either ultra low risk, and I'll talk a little bit about the ultra low risk, high risk 1, high risk 2. So if like for example, this was a high risk 1 score, there's some other information we can get from it. One, it shows us that there is a benefit to chemotherapy, but with the mama print, there has been further trials that in fact help us to choose the kind of chemotherapy. For example, patients with a high risk 1 score, the studies in the mama print show that they didn't benefit from the red drip, the so-called red devil. Right, so thankfully we are able to then say you need chemotherapy, but you don't have to have an anthracycline. You don't have to have the red drip, and so this also helps to some extent in treatment selection. There is a risk, a group of the ultra low risk, and have sometimes used this test to in a woman who has an obviously low risk cancer, who's very concerned about the side effects of hormone blockade, who already perhaps is older, already has arthritis, has joint pains, has osteoporosis, is worried about how hormonal blockade is going to affect her already weakened bones. And so there is a group that is ultra low risk, basically meaning the risk is so low that the woman is probably going to do fine anyway, because there we can then discuss perhaps a shorter duration of hormone blockade, like 2 years and so forth. It's a challenging one because the cost of the test, we know this genomic profiling tests are about 35 to 40,000 rand. And so sometimes the medical aid might be a little bit hesitant to pay 40,000 rand so that we don't take a tablet of 100 rand. But so far with motivation and stuff, we've managed to get it. So there is a role sometimes for that if we want to truncate the hormonal blockade. But in the main, the reason we do genomic profiling is to answer the chemo question and also to help see what kind of chemotherapy. For example, high risk 1, we know we can get away without the red drip, but high risk 2 is really high risk where we'd have to have the red drip, like adriamycin, followed by the weekly treatment, the Taxol. The other interesting thing about the mama print is that it also tells us whether you will benefit from long hormone blockade. Before, the duration of hormone blockade was always 5 years. And then there were studies that looked at 5 years compared to 10 years, particularly with tamoxifen, and showed that tamoxifen at 10 years was better and that there was a lower risk of the cancer coming back in the long term, right? But we know that sometimes when tumors are smaller, lymph nodes were negative, that perhaps the benefit for 10 years is marginal. So the mama print, in addition to telling us about whether someone is chemo or not, does give some information about the actual benefit of extended endocrine therapy, which is quite good because then even when we get to 5 years, we've got material from the tumor that tells us that we could confidently stop at 5 years, that there would be no additional benefit to 10 years. So the genomic profiling really does give us a lot of information surrounding treatment options. So genomic profiling helps us understand the personality of the cancer and how best to keep it from returning. It's a personalized care plan that looks at your particular cancer and not just a general breast cancer. The big advantage is that it can prevent unnecessary chemotherapy and it helps us to make decisions with confidence. I'm gonna pause here. I didn't want to make it too long, just so that we can just have more time to chat and to answer your questions. Thank you.
Thank you so much. Sure. A lot of information to absorb and make sense of in this brain. Anybody have any questions for Dr. Tabane?
I just want to say thank you. That was very enlightening, and I wish I'd known this before my treatment started. Thank you very much.
Dr. Tabane, so that on that point from Priscilla, can you only do this testing at the beginning of treatment? You can't do it retrospectively or somewhere in the middle?
Yeah, so there's 2 points that we can do this. We can do it. So in the main, we've done it after you've had surgery, right? But there's 2 points we can do it. You can do it after a biopsy. So let's say you've just had a mammogram, they've seen something concerning, and there's a biopsy, right? So that's confirmed a breast cancer. And perhaps let's say there's a lymph node in the armpits that is also positive. And the biology is hormone receptor positive, as we've discussed, HER2 negative. But let's say perhaps we are uncertain whether you really need chemo, even though it's in the lymph node. We can do the oncotype at that time, right? Or the mama print and send it off to see what is the likelihood that you'll actually respond to primary chemotherapy. What is the risk of recurrence if we only treat with hormonal blockade? So we can sometimes do it at the biopsy to, if it's not clear whether someone needs chemotherapy or not, right? The other place to do it is after you've had an operation. So let's say the tumor was small enough for the surgeon to comfortably, and the multidisciplinary team have decided that it is ideal to take the cancer out first. And let's say then we do that, because remember, all new diagnoses must be discussed in a multidisciplinary team with the breast surgeon, radiologist, radiation oncologist, plastic surgeon, medical oncologist, all in attendance looking at your case. So let's say we agree that we must cut it out first. We can then do the oncotype or the mama print then after the op to determine whether you need surgery, whether you need chemo or not. But retrospectively, it tends not to be helpful, because then we can't go back and give the chemotherapy. There is a window of 3 months within which, if we're going to have chemotherapy, we need to have chemo. So if we give chemo too long after the initial window of 3 months, there is no benefit. So if we do the test a year later and we realize we should have given chemotherapy, that is not helpful, because we can't go back and the window of treatment would have closed. So we must either do it at diagnosis if there is an uncertainty about whether chemotherapy is required, or post-operatively to plan whether or not we go hormonal blockade alone or chemotherapy followed by hormone blockade.
Okay. And is there a overlap in terms of the genes that are tested between the oncotype and the mammoth print, with one being 21 and one being 70? Are they completely different genes?
No, there is an overlap. It's a
Okay.
completely different process, but there is an overlap of some common genes that are tested, yes.
So is the recommendation to do both, or do you decide on which one based on the type of cancer or the rate of growth or size of tumor, or how?
To be honest, you can do either. You can do
Okay.
either the oncotype or the mama print. Oftentimes it just depends on what the clinician is most comfortable with. But either oncotype or mama print, I've all been well validated, and so you can really do either.
Is this okay? So I'm a triple positive lady, so obviously this conversation would not have come up for me. So my question is this standard practice now when somebody comes into you with all oncologists, or is it still fairly new?
No, it is standard practice, but I must emphasize that we don't do genomic profiling on everyone. Let me give you an example. So let's say, for example, a 70-year-old woman comes with a 9mm tumor, which is low grade, meaning it is very slow. It is strongly hormone receptor positive, HER2 negative. It's got a very low rate of proliferation. You may have heard sometimes when the biopsy is discussed that we talk about a marker called the Ki67, which is the marker that shows what percentage of cells are actively cycling. Let's say that's very low. The cutoff is 14%. Let's say in this patient, it's 5%. So very slow cancer, small tumor, negative lymph nodes, 70-year-old postmenopausal woman. It is clear that this woman does not need chemotherapy. So then we don't need to test to tell us something that is that obvious. We could, but at the cost of 35,000 rand to tell us that you don't need treatment when all the pathological markers show that we don't, we don't always do the test in that regard, because we also have to manage the fiscus. We can't just do tests because they're available, especially when they're not 40,000 rand later, they tell us something. We that the team has agreed and all the markers of pathology show that you don't need chemotherapy. So we don't do it on everyone on that basis. In a perfect world where money was no object and no funds ran out and maybe that would happen, but that's not practical. But it's certainly something that as a patient, one can bring up with their doctor to say, are you planning to do genomic profiling? And if not, why not? So we can then say, no, it's because the tumor 7 millimeters, it's low grade, very low Ki 67 proliferation, strongly positive, postmenopausal, you don't need chemotherapy. And then if you are comfortable with that, we can then proceed. But of course, one can always bring it up for discussion.
Sure. How much of this does medical aid pay, if any?
The medical aid, so Discovery pays for it. Discovery pays for genomic profiling. It does take about 7 to 10 days. It does take time, but Discovery does pay. And also some other medical aids in med scheme do pay, but there are still some medical aids, unfortunately, that don't cover it, particularly under the med scheme banner.
Okay. Can genomic testing influence the duration required for hormone therapy?
Yes. So in the last slide of the mama print, there is, let me just go back to that. This one here, it shows that if you look at the bottom right, it says absolute benefit from extended endocrine therapy, meaning that in this patient, it shows that there is no benefit for going beyond 5 years. So the mama print test does give that additional information of how long should hormone blockade go on for. Can we stop at 5 years? So the durations are 5 versus 10 years for tamoxifen, or 5 versus 7 years for Laradex or letrozole or anastrozole. There is no good data for 10 years of an aromatase inhibitor. That is Laradex, Tradexa, that group.
Wow, that's interesting.
Yeah, so I'll tell you just about it now. So it's 5 years versus 10 years for tamoxifen, 5 years versus 7 for Laradex, Tradexa. And the reason for that is that there was a study that compared 7 years of Tradexa to 10 years of Tradexa. And they found no difference in risk of relapse, but they found more fractures in the 10-year group. More women broke their bones at 10 years on Laradex versus 7 years, because the Laradex accelerates bone density loss. So beyond 7 years, there really is no evidence of benefit, but there's certain evidence of poorer bone health.
Oh, wow. Okay, didn't know that either. That's great to know. We've got a lady, one of our ladies that are getting treatment at the moment in the Netherlands, and she sent through a message last night to say she has TNBC with apocrine features, which is apparently quite rare. And I don't know where that fits in terms of negatives and positives, but she said that she was actually advised here, and when she went for treatment at this oncology center in the Netherlands, that it wouldn't be of any help to her to have any of these tests. Are there other rare and specific types of cancers where it doesn't apply?
Yes, so triple negative breast cancer with apocrine is a particularly difficult, not difficult, but tricky cancer, in that although at the glance it's triple negative, it does not behave like the typical triple negative. Those they tend to not be as aggressive as the classical triple negative, and so we often in our meetings would have to discuss really whether someone needs chemotherapy and so forth. But yes, the difficulty is that these tests here have been validated for hormone receptor positive breast cancer. They have not been validated for triple negative breast cancer, even if it's apocrine. But yes, the apocrine triple negative is a slightly different kind of TRPNEC, and they tend not to behave as aggressively, and the prognosis is generally good.
Okay, so could we say with what you've been saying that triple positive is not good for testing either? So triple positive and triple negative are
Correct.
not okay.
Yeah, so the
Okay.
test has not been validated for HER2 positive and for
Yeah.
hormone receptor negative.
Okay. Any other questions, anybody? I've been hogging the questions. Now is your opportunity, ladies.
Nothing
And our
from my
gentlemen.
side.
Can you hear me, Dom?
Yes, I can hear you, Kate. Or Sally.
Sally?
Sorry, Sally. Go ahead, Sally.
Oh, no worries. Thank you, Dr. Tabane. That was very interesting. I'm really wondering if we could possibly do this again. I'm triple negative, so I would love to hear all these things about triple negative, and also immunotherapy, which I know is a story, but yeah, I'm actually having it, so I would really be keen to hear more and more about it.
Do you have
We
a
will
specific
definitely organize
question?
more.
Do you have a specific question that we could maybe just do one question for you?
Me, about the triple negative. Yeah, I didn't know all when I first got it. It's recurred. So I didn't really know about all this. I haven't got a specific question. I've just been listening to you and all the your information in my head, and I know a lot of it doesn't apply to me. So yeah, I have to think this one through, and then I'll maybe hand on questions to Dom, and if we do this again, you know.